Having a little difficulty here. There we go. Okay, so I was encouraged to kind of show some unknown cases initially. This is something that usually first, second, third year radiology residents may misinterpret. So we have a lot of developmental variants. This arrow, so we're looking at a lateral wrist radiograph in a pediatric patient with open physes. We see the wrist is normally aligned, so we've got our lunate, capitate aligned with the radius. Then we have this structure out here in the volar soft tissues. Looks kind of odd. And then one of the concepts that we have to deal with in looking at musculoskeletal imaging in kids is we know there's a lot of cartilage that goes on to mineralize. This happens to be the pisiform on the lateral view. It looks like it's kind of really distant from the other carpal bones. But we have to keep in mind that there's a lot of cartilage around here, and it starts to mineralize along with a lot of other secondary ossification centers in an irregular fashion. So this is just a normal pisiform on a lateral wrist radiograph. Here's another image. Child comes in with knee pain. We see this pretty frequently. This is actually a bipartite patella, so there can be additional ossification centers within the patella, sometimes as many as 3 or sometimes 4. So we see this frequently. It's always in the superior lateral aspect of the patella. This is a normal developmental variant. So this is a bipartite patella. Here's something, again, these are kind of usually things that you need to see at least once or twice before you learn not to mistake these for pathology. This is the frontal view of the knee. This patient still has open physes, but as we can see here, and this is actually the tibiotubercle, right? So this just happens to be a little bit odd in appearance on the frontal view. Here's what it looks like at this stage of development here on the lateral view. So that we're just seeing this structure here, the tibiotubercle, which will go on the fuse with the metaphysis a little bit later. But this is how it looks on the frontal view. Okay, this is a good one. So the growth plates are normally, in the lower extremities at least, straight across. Proximal humeral physis undulates, right? And so actually has kind of a mountain peak appearance. And this is what's referred to as a pseudofracture. And this is actually part of the physis here. It looks pretty strange. We see it quite frequently. But I think initially when you see it, especially in someone with a post-traumatic injury or something, it can be mistaken for a fracture. So normal appearance of the undulating proximal humeral physis. Here's another example of that, right? So kind of strange appearance of the proximal humeral physis. Again, here, these are those pseudofractures. This arrow points to kind of some smooth periosteal reaction here, which can be seen and not too worrisome. Okay, keeping with the theme from the original pisiform image, again, we have these secondary ossification centers all over the place. There's multiple about the elbow. One of the things we have to kind of come to understand is that, again, there's a lot of cartilage that goes on to mineralize. Unfortunately, it doesn't mineralize in a uniform fashion, so we get kind of some irregular mineralization. But this is the lateral epicondylar ossification center, cartilage around it. So this is normal. It can kind of look like it's potentially displaced or separate from the lateral condyle of the distal humerus. Okay, and then if we go back and look at this elbow on the frontal view, this is the medial epicondylar ossification center. And then this is the medial epicondylar ossification center on the lateral view. Okay, same theme, secondary ossification centers that go on to mineralize and can look kind of strange. This is the apophysis at the base of the fifth metatarsal, right? So a lot of cartilage around it. So radiographically, we can't see that cartilage. It's not radiopaque. When we go on with ultrasound or MR, we can actually come to see this. And I think that's part of the learning process for a lot of us is that once we start to see it on other imaging modalities, it starts to click and make sense. So here's a normal apophysis at the base of the fifth metatarsal, not to be confused with a fracture. And then here's that Jones fracture, right? So typically the secondary ossification center is kind of vertically oriented. When it's transversely oriented, that's when we start worrying about a fracture. So We also have these secondary ossification centers about the anterior superior and anterior inferior vertebral bodies or vertebral body end plates. So normal developmental variants. Okay, so now we'll move on to the bulk of the lecture about fractures. So one of the most frequent type of fractures we see are these fractures that involve the growth plate. They're referred to as Salter-Harris fractures. And we have 5 different varieties. I would say that the vast majority of the time, we don't recognize the Salter-Harris type 1 injuries or the widening uniformly of the growth plate. The type 2 injuries, where there's a fracture through the metaphysis. So again, we have diaphysis, metaphysis, and epiphysis. Metaphysis and epiphysis are separated by the growth plate. The most common Salter-Harris fracture is the type 2, where there's a fracture through the metaphysis that extends to the growth plate. The type 3 is actually a fracture through the epiphysis extending to the growth plate. The type 4 is actually a fracture through the epiphysis, growth plate, and metaphysis. And then the type 5 is a crush injury that we also don't usually recognize radiographically. So our concerns for any of these, the type 2, 3, 4, and 5, would be some type of abnormal healing or growth arrest where you end up with bony formation that bridges the physis and therefore tethers the physis and leads to stunted growth or angular growth. As we get into a type 3 and 4, and we'll look at some examples, what we're concerned about primarily, in addition to the growth plate injury and the potential for growth arrest or bony bar formation, is actually the gap at the articular surface. So you can imagine there's articular cartilage and oftentimes epiphyseal cartilage here, and that gap there can disrupt that and eventually lead to early onset osteoarthritis. So depending on the width of the gap, orthopedic surgeons may choose to actually close this gap with orthopedic hardware. So here's an example of a Salter-Harris type 1 injury where we've actually got widening of the growth plate, kind of a subtle finding. The idea behind the Salter-Harris classification is as the numbers increase, the likelihood of some type of growth arrest or bony bar formation in the physis also increases. Some other factors that can contribute are kind of the configuration of the physis. So kind of a linear configuration straight across, less likely to have a growth arrest. We saw in that example previously that the kind of undulating configuration of the proximal humeral physis would be more likely to contribute to a growth arrest. Fortunately, the majority of times we see the Salter-Harris injuries, they tend to be in the lower extremities, and the growth plates are pretty much transverse in orientation. So here's our Salter-Harris or type 2 fracture, right? So we've got fracture through the metaphysis, which extends to the growth plate. If you notice here, we've also got a fracture of the distal ulna. Okay, so here, so we've got our radiograph, which looks a little bit strange. I don't know how well it projects, but it looks like there's probably disruption of the articular surface here, which extends to the physis. We get the CT scan, you can actually see that there's widening in the growth plate and then that fracture that extends to the articular surface. I would say this is probably less than a 1 millimeter gap, so not something to be worried about. Additionally, we have an injury to the physis of the distal fibula in this image. All right, so here is a 3D volume rendered image of the distal tibia and fibula, different patient. And this is our Salter-Harris 4 fracture, where involved the epiphysis, the physis, and the metaphysis. And this is actually another term for this type of injury, is a triplane fracture. So we have the first plane, the second plane across, and then the third plane involving the metaphysis. As I mentioned, our main concern in the Salter-Harris type 3 and type 4 fractures, which involve the epiphysis and therefore the articular surface, is that displacement at the articular surface and the injury to the articular cartilage. So in general, a rule of thumb is, does that bony gap measure 2 millimeters or more. When we start to measure at more than 2 millimeters, we start to mention that in our reports and leave it up to the orthopedic surgeons if they want to fix it surgically. Another thing we're looking for is there some type of offset? So does it kind of go gap down and around? So we're looking for that gap of the articular surface as well as the offset between the fracture fragments of the articular surface. The toddler's fracture, there's a few different types. Typically, we see this in kids that are just less than a year to about 3 years of age when they're starting to walk. Usually the patients can't localize the pain or provide an appropriate history, and they present with a limp. In our example here, so these are pretty subtle, so we need to know where to look. You can just barely see a obliquely oriented lucency within the distal tibial diametaphysis. So that actually involves both the diaphysis and the metaphysis. So we look there in the distal tibia. That's the classic toddler's fracture. Let's see, where else do we see it? Well, we can see it in the proximal tibia. We can see it in the mid tibia. We can see it in the calcaneus, the cuboid, and then the metatarsals. The proximal tibial fracture here is also referred to as the trampoline fracture. And that has to do with, I don't know how many of you have been on a trampoline, but sometimes when there's an adult and they mistime their bounce with the child, that force can actually translate up to the tibia and result in a buckling of the diametaphyseal junction. So one of the things we look for, or one of the spots we always look for, is this transition from the thick cortex to the thin cortex. And that's actually a transition from the diaphysis to the metaphysis. So if we look here, thick cortex, thin cortex, thick cortex, thin cortex, right there, that's a transition, and that's a point of weakness. And I'd say the majority of these type of buccal fractures or even toddler's fractures tend to occur right there. We can see it on the lateral view better than the frontal view. Okay, so this is another subtle one. So we have to know where to look. So we look in the posterior aspect of the calcaneal, not the calcaneal, but the cuboid ossification center. And there's a little bit of sclerosis there. And that's resulting from kind of a nutcracker effect of toe walking. So you get this kind of impingement between the calcaneus and the fifth and fourth metatarsals and the cuboid. Here's another example right there. Pretty subtle, so we have to know where to look. Here's an example of that calcaneal stress injury or that calcaneal toddler's fracture. And then more skeletally mature patient, so not so much a toddler's fracture, but we do tend to see these early healing changes in the mid metatarsals related to stress type injury. Okay, buccal fractures, so we kind of covered some of the themes around that. Again, where are we looking? So we're looking for that transition between the thick cortex and the thin cortex. So this is the diaphysis as we go to the metaphysis. And right there, we can kind of see some buckling. Here, thick cortex to thin cortex. So right there, point of weakness. We get a little bump right there. So if you mentioned buccal fracture, typically these are splinted and sent home. They don't necessarily need follow-up. Whereas other type of fractures, ideally the Salter-Harris fractures, which can actually lead to a growth arrest, typically get follow-up with a specialist. Here's that abnormal contour, both the distal ulna and distal radius related to that cortical buckling. This is kind of a subtle one. Okay, so more obvious buckling. So how do these heal? All right, so typically in long bone fractures, where there's some high impact or high degree of force, we have expected healing changes. So the typically when there's some type of displacement in a fracture, we'll have injury to the periosteum, which is vascular. That periosteum will bleed and result in a subperiosteal hematoma. That hematoma elevates the periosteum, and we get some mineralization in the periosteum. And the first thing we see is the periosteal reaction. Then we see that mineralization of the hematoma, which is called the callus formation. And then that callus kind of bridges the fracture site and eventually fills in the fracture site and leads to reshaping back to the normal configuration of the bone. That's called remodeling. And these kind of low impact fractures, like buccal fractures, we may not see those healing changes in that kind of regimented fashion. Instead, we may see just a touch of periosteal elevation and potentially some intramedullary bony sclerosis. So not much impact, not much injury to the periosteum, and therefore more subtle healing changes that look different. All right, so elbow fractures. So we have a whole laundry list of different types of elbow fractures. So we have most frequently is the supracondylar fracture, and we'll look at some examples of those. The lateral condylar fracture, less frequent medial epicondylar avulsion fracture, where we kind of pull off that medial epicondylar ossification center. Those would be the most common. I don't know if I've actually called it transphyseal fracture. We see radial neck fractures not infrequently. We'll see an example of that. On occasion, we'll see olecranon fractures. And I would say that, the remainder of the fractures are pretty uncommon. On occasion, we'll see a coronoid process fracture where the tip of the coronoid is fractured. And then medial and lateral condylar fractures, right? So that's actually the medial condylar fracture is actually when the patient is skeletally mature. And then the lateral epicondylar fracture, pretty rare. Sometimes we'll get an avulsion injury at the ligaments there. Okay, so one of the first things that we may see as a manifestation of an occult fracture is a joint effusion. These joint effusions can kind of point us in the direction that there may be some type of injury without a displaced fracture. So what do we look for? Well, these are actually fat pads here, and I'll show you a graphic in a minute. And these fat pads, here's the actual joint capsule, comes up here. When that joint capsule gets distended, it elevates both the anterior and posterior fat pads. So this is a secondary finding of a joint effusion. The joint effusion is actually here, the fluid within the capsule, but hard to see radiographically. So we look for these manifestations. So elevated posterior fat pad is always abnormal. On occasion, we'll see mild elevation of the anterior fat pad, which can be normal. All right, so here's the graphic, right? So we have, here's our fat pads here. Here's the joint capsule, which extends down to the proximal radial metadiaphysis. When we have too much fluid in there, it starts to elevate those fat pads. We can see them radiographically. Again, posterior fat pad sign or visualization of that posterior fat pad is always abnormal. What's the most common type of occult fracture that we see related to a isolated joint effusion is typically the radial neck. So what we recommend, knowing that these healing changes kind of occur in a regimented fashion, is we recommend a follow-up radiograph in 10 to 14 days. And why do we do that? Well, that visualization of that periosteal reaction is one of the few things we know for dating fractures, which is, and it typically occurs between 8 and 10 days. Hence the logic behind recommending a follow-up to see, in fact, if we can see those radiographic manifestations of healing, and we typically see it at the radial neck. Okay, so elbow alignment, right? So here's a lateral view of the elbow. What we typically look for is we draw a couple different lines. So we'll draw the anterior humeral line. It should go through the anterior 1/3 of the capitellum on the lateral view. Additionally, we draw the radiocapitellar line, and that should go through the long axis of the radius and the capitellum, the mid portion of the capitellum, on both the frontal and lateral views. So the anterior humeral line is used to actually try to identify a subtle supracondylar fracture, and the radiocapitellar line is actually used to identify a subtle radial head subluxation or dislocation. One of the structures we saw before happens to be this medial epicondylar ossification center. We can kind of just see that on this lateral view kind of pooching out there. So here, what do we have? Well, we have our elevation of the anterior fat pad. We have our elevation of the posterior fat pad. So we've got a joint effusion. Again, here's the joint capsule here. Let's see, we identify our capitellum. We draw our anterior humeral line, and it goes through the mid portion of the capitellum, but just barely, right? So we probably want it here. So this looks like potentially like a subtle supracondylar fraction. And then we draw again, not only on the lateral view, but we draw our radiocapitellar line through the lateral, and then again through the anterior aspect of the long axis, the radius, so we make sure that we don't have a proximal radial dislocation or subluxation. Okay, so this is a more significant fracture. So again, big joint effusion. So in this case, we have elevation of the posterior fat pad, not a big elevation of the anterior fat pad. So again, always pathologic, that elevation of the posterior fat pad. We can see kind of the fracture here. And then if we, again, identify a radiocapitellar line, in this particular case, the anterior humeral line does not even come close to the anterior 1/3 of the capitellum on the lateral view. So we know we have a more displaced supracondylar fracture, but it looks like the posterior cortex is intact. And then again, so radiocapitellar line, long axis of the radius through the capitellum on both the frontal and lateral views. So this is the classification system for supracondylar fractures. So we saw that minimally displaced supracondylar fracture on the initial image. This is the type 2 Gartland supracondylar fracture, is displaced fracture with intact posterior cortex, like we saw in the previous example. Here, intact posterior cortex. And then complete displacement, where there's disruption of that posterior cortex and that distal fracture fragment is displaced, is a type 3. Okay, so here's an example. We can see some arrows here. This arrow kind of denotes a proximal ulnar diaphyseal fracture. And then here's actually, if we draw our radiocapitellar line through the long axis, the radius doesn't intersect with the capitellum. So we have a dislocated radial head. This is a Montesia fracture. So it's the proximal ulnar diaphyseal fracture with the associated radiocapitellar dislocation. Radiocapitellar dislocation can be traumatic or congenital. A couple of things we look for. So obviously the fracture for the Montesia, so proximal ulnar fracture. So when we see the ulnar fracture, we always want to look back at the elbow, make sure there's not a secondary subluxation or dislocation. If these aren't identified, they can have pretty significant impact on the pediatric elbow. And in the United States, at least, this is one of the top reasons for lawsuits. And then we have a congenital dislocation. We can actually see that without the normal articulation of the radial head with the capitellum, we get underdevelopment of the proximal radius, and then we actually get a little bit of indentation here within the distal ulna or distal humerus anteriorly. So this is kind of a neo-articulation here, and then we get underdevelopment here. So both congenital and traumatic options are both options for when we see the radial head dislocation. I will say that the vast majority of the time we're seeing this post-traumatic. So, and again, we always want to look for at the elbow when we see the radial or proximal ulnar fracture. Okay, and then here's our type 3, Gartland type 3 supracondylar fracture. So we've got complete disruption of that posterior cortex. The distal fracture fragment is actually displaced posteriorly. Anterior humeral line is completely off, right? So it doesn't intersect or even come close to actually going through the anterior 1/3 of the capitellum. We draw our radiocapitellar line. We see that that's, in spite of the pretty significant fracture, that's still intact, so we don't have a radial head dislocation. This is kind of an interesting one. So this is a capitellar fracture, pretty rare. I don't think I've seen many of these in my career, but we can actually see that the capitellum here has been fractured and displaced, resulting in a abnormal radiocapitellar line. Took up a chunk of the lateral condyle of the distal humerus with it, and actually displaced the whole fracture fragment. All right, so radial neck fractures. We see these quite frequently, right? So this is one of those buckle type fractures that may or may not have some displacement. This is how we grade them, right? So we actually look at that junction of the or the thick cortex to the thin cortex, and we go from the diaphysis to metaphysis. They tend to occur right at that junction, and then the degree is actually dependent on the angulation associated with that fracture. So minimally angulated, moderately angulated, severely angulated, and that gives us the severity of the fracture. So here on both the lateral and frontal views, again, we go from that thick cortex to that thin cortex, and we see the fracture right at that point of weakness. This is kind of a mildly angulated fracture here, the radial neck. So radial neck is that diametaphyseal junction. This is the point of weakness in kids. Again, multiple locations where we have that point of weakness. In adults, we tend to see a radial head fracture, or the at the level of the closed physis, we start to see the fracture here at the point of weakness in adults. Okay, so ACL injuries in kids. What are we looking for? So usually it's a subtle finding here at the lateral aspect of the proximal tibia, and that's referred to as a Sagan fracture. We're still not exactly sure what's avulsed. I think the leading theory right now is that it's part of the iliotibial band that pulls off that bone, but it's frequently associated with a anterior cruciate ligament fracture. So we see that little tiny avulsion fracture at the lateral aspect of the proximal tibia. We know it's a Sagan fracture, and we know there's a likelihood that there's a post-traumatic ACL injury. At least in our country, we'll move on to MR. These are frequently associated with pretty big joint effusions. And then another point of weakness in kids. So typically the ligament isn't injured, the anterior cruciate ligament, but the tibial eminence here is actually avulsed. So that's the point of weakness in the developing skeleton. These come in 3 different varieties. So we talk about type 1, 2, and 3. So a type 1 is not displaced. A type 2 is kind of hinged like a trapdoor posteriorly, and a type 3 is displaced. What's kind of interesting about these fractures is when we get the radiographs and we identify a tibial eminence fracture, and we use that classification, it's a static image. So on a static image, it may not appear displaced, but on a, I suppose if we were to do dynamic imaging, maybe we could displace it. So for that reason, at least in our country, many folks or many surgeons actually advocate for a MRI to actually see if there's some type of entrapped structure. So what could feasibly be entrapped beneath that? So if there's an entrapped structure beneath this fracture fragment, it's not going to heal appropriately. And when we're looking at the MRI, we're actually looking for the anterior horn of the lateral meniscus, which can get entrapped. There's actually an intrameniscal ligament, which goes from the lateral to medial anterior horns of the meniscus that can get entrapped there. So there is a possibility that something gets stuck underneath this fracture fragment. Okay, so little toes and fingers. So before we get into this particular fracture, this is kind of my search pattern is so even though we can see those buccal fractures quite easily in the long bones, like the distal radius, like we saw the example there, or potentially the proximal radius or ulna, and the little fingers and toes, I'm always looking at that transition from the thick cortex to the thin cortex to see that point of weakness. We can pick up on these little buccal fractures. This is kind of a typical appearance of a Salter-Harris type 2 fracture of one of the digits. So we get these little bone fragments here. We've got some widening of the dorsal aspect of the physis. And I've always, thought when I was initially learning about this, well, couldn't the fracture fragments come from the epiphysis? And this is feasibly be a Salter 3. It's always a Salter 2. So we see this quite frequently. We're always looking for injury to the nail bed as well. So this is a Salter-Harris 2 fracture. This would probably be treated conservatively, looking for injury to the nail bed as well. And I suppose if there was a growth arrest here, we may have a little bit shorter toe, so not a really big deal, but we do see this type of fracture quite often. This is the mechanism, right? So there's some type of trauma when the distal interphalangeal joint is flexed. That results in traction on the dorsal aspect of the physis, and we get kind of that injury from the fracture fragments from the metaphysis. So why are we worried about the nail bed? Well, between the nail bed and the bone, there's a very small amount of tissue. So if the nail bed is breached, there's a higher likelihood of post-traumatic osteomyelitis. So oftentimes in my report, I'll say injury to the nail bed, consider treating prophylactically with antibiotics for osteomyelitis. So even though we may not see a fracture associated with that bone, underlying bone, if there's injury to the nail bed, we want to be careful just because there's not much of a barrier between the nail bed and the actual bone itself for bacterial seeding for osteomyelitis. Okay, so here's a pretty bad fracture. Doesn't project very well, but in this particular case, we can see that there's some injury to the nail bed, so high likelihood of osteomyelitis, and should probably be treated prophylactically with antibiotics. This is a pretty bad fracture here, so it looks like it involves the metaphysis, potentially the epiphysis, so this could be a Salter 4. Again, not so worried about the growth arrest, just about the healing. Okay, so this abuse-related fractures. So let's see. So when I was in Ethiopia recently, I kind of discussed this a little bit with some of the radiology residents there, but just want to educate you all what we see and what we're looking for fractures that are highly specific for abuse. Okay, so this is a great graphic that kind of illustrates the mechanism that results in the majority of findings with abuse. So we've got the hands position around the infant, and when we start thinking about abuse, what age group are we actually thinking about? Well, we're thinking about the majority of abuse occurs, and get back to that one, in patients that are between or less than a year of age, and then also less than 3 years of age. So approximately 50% of abuse occurs in kids less than a year of age, and then 75% less than 3 years of age. So when I'm thinking about abuse-related injuries, I'm thinking about younger patients, and I'm thinking about this type of mechanism. So how do we get this? So the thumbs are positioned over the sternum, the fingers are positioned over the posterior spine and ribs. This shaking motion back and forth actually results in ligamentous injury of the spine, potentially the cervical spine, but we can also have injury down the thoracolumbar spine. The back and forth motion results in tearing in the bridging veins in the head, and the resultant subdural hematomas. And then as we look at, okay, so what are the fractures that are highly specific for abuse? So we'll talk about the classic metaphyseal lesions separate, but rib fractures, right? So you can imagine squeezing the thorax, can actually result in rib fractures. We talk about the direct force being on the posterior medial ribs. But when you squeeze a pretzel or you break a pretzel, you need to actually break it in two spots. So we can get lateral rib fractures, we can get anterior rib fractures. And then you talk about scapular fractures. So again, force right there on the shoulders. So we can get scapular fractures. We can get spinous process fractures from force directly on the spinous process of the spine. And then the thumb's positioned over the sternum. So this is a great graphic that kind of illustrates what we're looking for. We're looking for those rib fractures, scapular fractures, spinous process fractures, and sternal fractures. So unless you're looking at a lateral view of a chest or a spine for a sternal fracture, you're going to miss it. And unless you're looking for a spinous process fracture on a lateral view of the spine, you're going to miss it. Scapular fractures tend to be relatively occult unless you're looking for them. Rib fractures can be pretty difficult to identify. And in addition, now we're also actually looking at the costochondral junctions for fractures as well. So some of the things I think when I first saw this list that I was surprised to hear were not like highly specific for abuse were complex skull fractures or lineal skull fractures. We have kids that fall and hit their head quite frequently, so not highly specific. So we're mainly looking for these bottom four on our skeletal survey. Now the classic metaphyseal lesion, so that's a different type of injury, different mechanism that occurs at the metaphyses of the long bones from pulling and twisting of the limb. So younger patients, less than one, they're pulling and getting kind of manipulated by their limbs, result in this unique type of injury, and we'll see some examples of that. Okay, so here's this rib fractures, right? So actual direct impact here result in the posterior medial fractures, but we can also have the lateral fractures, anterior fractures, and the costochondral junction fractures. So here's some healing fractures posterior. Here's some healing fractures lateral. And again, on the opposing side, healing fractures lateral. So we get that robust callus formation there. Here's some more posterior fractures on the opposing side. Here they are on a separate patient for chest CT. So you've got some acute and then early healing changes for rib fractures. Okay, so here's some examples. So a scapular fracture, pretty subtle spinous process fracture, pretty subtle sternal fracture. So again, unless you're really looking in those locations, it's going to be pretty easy not to pick up on those, especially if you have a larger field of view. Okay, the classic metaphyseal lesion. So I think before we talk about that injury to that metaphysis that results from pulling and twisting of the limbs in the younger patients, we need to recognize that there's some normal structures of the metaphysis that can be beneficial, I suppose could be confusing if in fact you weren't aware of them. So there's two components to what's called the perichondrium. Perichondrium is the tight attachment in the periphery of the metaphysis, which extends down to the level of physis. This actually illustrates the two components. So there's metaphyseal bone collar, metaphyseal bone spur. So when I'm looking at cases where there's concern for abuse, when I see this, I'm actually quite happy because I know they're normal. So first and most importantly, know that these structures exist. We can see them on radiographs, we can see them on CT, we can see them on ultrasound, we can see them on MRI. One of the things we'll use is if we're not exactly sure, we could actually use ultrasound to look at this area as well because it shows up quite well. Okay, so here's an example from this article from 2019. So here we have our normal structure, and then here we have our metaphyseal, classic metaphyseal lesions, or these abuse-related fractures of the metaphysis. So again, looks pretty different, but recognizing this is kind of important. So we use some other terms. So we call it the classic metaphyseal lesion. We call it the corner fracture, and we call it the bucket handle fracture. So here's kind of that bucket handle configuration, and here's that corner fracture configuration. These are the same fractures. It just depends on the projection of the image. So the corner fracture has this appearance on the lateral view, bucket handle fracture on the frontal view. This arrow is actually pointing to the normal perichondrium there, so normal structure here. Here's some more examples of these kind of areas of classic metaphyseal lesions related to abuse. Here's one. All right, so that's what I have on fractures.